Greetings to everyone that's participating in this 47th case presentation. First of all, let me wish everyone the best holiday wishes and a very pleasant end of December. The initiative that we're seeing here today, which is a case presentation on Zoom, represents a core initiative for SOGI. This is going to continue through 2026 and right up until the meeting in Ahmedabad in November. It's an open meeting. You can view it as it's being presented or pull it up later. It is unique. It's a tremendous effort. I'm going to be here for all of the cases, and I'm really wanting to see many of you return on a monthly basis for this important event. And so I'll give the meeting back to Aditi Bhatt, who will present the case for us today.
Thank you, Dr. Sugarbaker, and thank you for being there. I'd also like to welcome a very esteemed panel, Professor Somashekar, who is well known as a surgical oncologist and a peritoneal cancer specialist, not just in India, but all over the world. Professor Artem Stepanyan, who is a surgeon and a gynae oncologist both, and has a huge following for his surgical techniques, not just in cytoreductive surgery, but also in gynae oncology. And last but not the least, Dr. Arthur Rees, who is a young PSM surgeon from Sao Paulo, who's a great ambassador for peritoneal surface malignancies. So today we've got a tough case. It's a patient with advanced ovarian cancer who had unresectable disease to begin with, and the disease remained unresectable after 3 cycles of neoadjuvant chemotherapy. So we will be discussing the best management strategies for this situation. All of you are welcome to put your questions in the chat or in the Q&A, and we will answer them at the earliest possible. If there's something pressing that you want to ask, you can raise your hands and we will allow you to speak. So let's get started. The patient is a 75-year-old lady. She's got 4 children. The only comorbidity she has is hypertension. Her mother had esophageal cancer, which was diagnosed at the age of 80. And her presenting complaints were heaviness of the abdomen with pain, which was progressive in nature. This was present for a few months. Nausea, difficulty in passing flatters, fever with weakness, and occasional shortness of breath. So my first question to the panel is, she's 75. What is your definition of old age or geriatric population? Do you have any?
Maybe
Yeah.
Aditi,
Hmm.
and I can take this question.
Hmm.
We all know that in oncology, age is just a number. We
Hmm.
may actually have a younger patient who has abused his body with smoking or bad habits, and lung compliance, performance status may be poor, may not be fit for a curative treatment. But we may yet have an elderly patient who is extremely good in performance status, where we should and cannot deny a curative treatment. Having said that, if you go by the SIOG, the International Society of Geriatric Oncology Society's guideline, they take a numerical cutoff of 65 years. It's a little bit how 65, why not 61, why not 70 stuff. But having said that, the NCCN and SIOG take 65 as a geriatric population. But this number in itself should not be any reason to change the line of treatment, which is standard internationally. Having said that, we know that NCCN brings a separate set of guideline for elderly patient, where other than the standard of care, de-escalation is permitted, and that line is 72 years. That's something which is irony. NCCN brings de-escalated treatment at 72 years, but accept geriatric population as 65 years and above. So this is about the number.
Okay. Uh,
Yeah, totally agree. Totally agree. Now, the age per itself, it's not a contraindication, but somehow we need to have some point of attention to when we are above these numbers to be uh, attent and be careful with the indications and the morbidity that we can have.
yeah, I completely agree with that. Dr. Sugarbaker, do you have anything to say about this?
I'm just always worried over the age of 75 about our ability to rescue if there is a serious complication. If
Yeah.
everything goes well, these aged people can do almost incredibly well, and it's very satisfying. But if there is a major adverse event, they often go south rather than recover.
Yeah. So
Yeah.
age does take its toll, even if the patient has, even if all the workup, everything is negative, but the ability to recover from complications is definitely compromised. Artem, would you like to say anything? And would any
Yeah,
of you,
I
yeah.
I rather would rely on performance status and frailty score of the patient
Mm,
because such a threshold 75 or 70 or 80, it's just a number, and very often this number does not really reflect the real status of the body of the patient. So that, of course, the age is important, but I would really more rely on the performance status and frailty score of the patient in making a decision about the extent of our surgery. That's our approach to the surgery.
yeah.
What,
And if,
Arthur, what frailty score do you like to use?
Uh, it's just the first one I use is the hand grip test. You ask the patient to shake your hand with the maximum effort, and it is, very well reflects the state of the patient. And alternatively, we can, measure the sarcopenia index by CAT scan, measuring the psoas muscle, whatever. So it's the complex factors assessing this. There are different ways to assess, but we mostly assess the physical activity, the ability to walk, the hand grip test, and other metrics that you will very well know very well, I think.
You know
But for me,
the
hand grip test is the best point.
Really? Okay.
okay.
there are several assessment tests that we can use to predict somehow this kind of complications. But one thing that I'd like to use is the time of neoadjuvant treatment to start a program of pre-habilitation. And for these frail patients and this geriatric subgroup of patients, we can use also this kind of exercise to predict how the patient will be during a complication. Like if the patient is not able to go on more than 10 steps of a of stairs, probably if this patient suffers a septic shock, it's going to be hard to recover because the cardiopulmonary capacity of the patient is quite low. So using this kind of like physiotherapy or program, we could also understand and predict how is going to be the behavior during a hard scenario that could be a lot of them. So it's nice to understand.
Yeah. And if there is a geriatric medicine department, I think it really helps. It helps
Yeah,
in patient selection and preparation for surgery.
yeah, yeah.
So, moving on, she had an ultrasound of the abdomen and pelvis, which showed moderate ascites. The ascitic fluid cytology was positive for tumor cells. PAX8, WT1, and P53 were positive, suggestive of metastatic high-grade serous carcinoma. An omental biopsy was performed, which also showed metastatic high-grade serous carcinoma of ovarian origin. And these are the tumor markers. CA125 is elevated, but CA99 are normal. BRCA testing was performed. There were no BRCA mutations, and she was homologous repair proficient. Mhm. Slides are stuck. Okay. So this is her CT scan, and there's a lot of disease. There's gross ascites, there's diffuse nodular omental, mesenteric and peritoneal thickening, an omental cake. There are bilateral adnexal masses. I'm just reading out the radiology report, and there's a lot of disease in the pelvis as well. So I'm just going to play the scan once again so all of you can have a good look at it. So this is what we have. We have a positive biopsy. The ascitic fluid cytology is positive. There's no disease in the thorax. The disease is confined to the abdominal cavity, and there is a lot of disease. This evaluation was done elsewhere, so we do not have the radiological PCI. What would you do at this point? Would you perform any additional imaging like MRI peritoneum or consider a staging laparoscopy?
Yeah, so I agree that FTG PET is not extremely reliable, especially it would really miss the volume of disease in small bowel, mesentery, and various areas, and also based on the grade of the disease. I know it's a high grade here. There would be little difficult to map the small bowel serosa. That's something which is extremely important. Mesentery small bowel disease on the serosa is something which would decide able to achieve CC0 or not. So pretty much what you have put here is what would be done in my institution. We always prefer an MRI peritoneum, and we would do a staging laparoscopy before we contemplate whether it's a primary surgery or it's going to be a neoadjuvant chemo with interval cytoreduction. These two would be the working horse in my hospital.
Okay.
Yeah, agree. By my side, we also like to use CT and also MRI. Sometimes PET could be useful, also PET FAP, but we probably would go with staging laparoscopy and then to evaluate the small bowel, to evaluate the port hepatis, and this kind of scenarios that could predict not achieving the complete cytoreduction.
I
Okay.
might just comment that here the GYN group would uh, um, perform a staging laparoscopy, but it's not it's not actually going to make a difference in terms of the treatment alternatives. We know where this patient is going with treatment, but we would like to record as accurately as possible. And the CT does not give us that accuracy. Where is the disease? And record that carefully, video it, and then we'll come back to that laparoscopy later on after the neoadjuvant chemotherapy has been completed. In many
Awesome.
non-academic institutions in the United States, this patient would go straight to the neoadjuvant chemotherapy. No staging laparoscopy, no MRI. We have the information. We know what the best, we know what the next step is in the treatment. And of course, many of these people are managed by healthcare, commercial healthcare groups, and they're not going to use any test that's not absolutely necessary because it's going to increase the cost.
Yeah, it is pretty much the same in India, except for certain institutions, the public institutions, and some high volume centers where the surgeons have a stronghold. Most of these patients get referred directly to the medical oncologist and they undergo neoadjuvant chemotherapy without a surgical consult. I think even if at the end of it, neoadjuvant chemotherapy is planned, a surgical consult at the time of diagnosis is essential. Do you all agree?
Yes,
Yeah.
it's very common since the number of centers were able to achieve no gross complete resection for carcinomatosis is low. And
Yes.
of course, the indication for upfront surgery versus neoadjuvant depends on the PCI, depends on patient performance status, but in very big percent of cases, it depends on the expertise of the team and expertise of the surgeon. It's very difficult, to triage same patient in different hospitals. And that's once again improve to refer those patients to specialized centers. As for our team, we usually use the CAT scan to assess the burden of the disease. And what we use more, it is not specific to majority of carcinomatosis centers. We have so-called expert ultrasound. It is very, very operator dependent method, radiologic, by the specialist who is very dedicated to assessment of spread of carcinomatosis. And we did a retrospective analysis, and the compliance to the real, pattern in the abdominal cavity was very high. When we use this expert ultrasound, they are nicely calculate the peritoneal cancer index in all regions, especially in patients with ascites. Because when the patient has ascites, the ultrasound specialist use this fluid like a lens, and they calculate it. And at the very end, of course, the very useful is that the laparoscopy with the calculation of predictive index value. It's very common amongst the so-called Fagotti index.
Yeah.
This is usually how we do. We do the laparoscopy. We calculate the predictive index value, but we triage the patients basically on CAT scan and with this expert ultrasound. And some patients have such a huge amount of disease that they go to the biopsy and immediately to the neoadjuvant chemotherapy. The number is not high, but there is such a group of patients who do not undergo the diagnostic laparoscopy, having very high CA 1 to 5 and having real the pattern of very, very extensive disease that we, have no chance to achieve the complete gross resection. That's how we do.
Okay.
Yeah.
Yeah.
Just a comment. Totally agree with Professor Paul and Artem said. There's something interesting because in my center I am lucky because the two groups that work in the gyno groups, they would go, like Artem said, to a video to stage well, and these patients are normally very well treated. As a specialist, I see a lot of second opinion of patients that are in a scenario after response to chemo, after another try of a complete cytoreduction, and in these cases would be awesome to have the first video of the patient recorded, or if I have done this first video, probably I would spare some patients to the like to the probability of a false cytoreduction, like an open and close, and to spare them from this, and would also have a plan and a nice strategy to become and to try the second time. So it is very nice to have this video, but in Brazil also a lot of patients start treatment without a video on the beginning.
Okay. So I guess everyone agrees that staging laparoscopy, whenever it's feasible, except for the few patients where it's obvious that the disease is unresectable. Dr. Somashekar, you were saying something?
Yeah, no, also it is very important to note the randomized control trials done in excellent gyne-onco centers, both in UK and Europe, like URTC 55971, just had 36% CC0. Remember that. And they are all not general gynecologist, gyne-onco units. And even if you look in Chorus trial in a specialist center, the optimal cytoreduction rates, those time the GOG defined optimal cytoreduction as less than 1 centimeter. So it's very important to know. Even then, it was very low. And even if you look Scorpio trial, it was 70% only. So it's always nice to know a good staging laparoscopy. It doesn't matter. You can keep option ready for a curative cytoreductive surgery and then go in with a midline laparoscopy because you cannot predict a miliary disease on the small bowel, which might sometimes be the limiting factor. And many times
Yeah.
this PCI index in itself is not a contraindication because it's a combination of the volume of disease, what effort it takes to achieve cytoreduction. You can make out a plan. How many bowel resection? Is it just a rectosigmoid or a small bowel and diaphragm disease? And what is the duration of surgery and the anesthesia? And then the performance status of the patient and the reserve and the rescue mechanism available in your center if the patient ends up with morbidity, which we all know is almost 20% in Calvin Tindo in a high setup like that. Combination of all the three. So staging laparoscopy does help in this selected group of patients to make a plan. The same case may be cytoreducible in a different center with a team with a different rescue mechanism but may not be in your center. So it's very important to understand strength, weakness of where you are going to treat that patient and your rescue mechanism, and then the patient performance, and then formulate. Because the worst thing that can happen to the patient is you do a negative laparotomy, you open and close with a biopsy. That's like the worst that can happen to the patient.
Yeah, I completely agree with you. That's a very important message. You have to know your strengths and limitations and then plan the procedure according to your own skills and the resources and the team that you have. So this is, then we have to talk about resectability. So this is a score by Memorial Sloan Kettering, and they've got a list of features which are sort of adverse features, and presence of few or more of them are indicative of unresectability. So based on this, they've devised a score. And if the score is between 0 to 6, then primary surgery could directly be performed. or the surgeon could opt for a diagnostic laparoscopy. But if the score is 7 or more, then there is a high probability of unresectability, and diagnostic laparoscopy is recommended. This is, I would say, the gynae oncologist perspective. As surgical oncologists, we follow the principles that have been taught to us by Paul Sugar Baker. So our contraindications for surgery are extensive bowel involvement, patients that require a total gastrectomy and a total colectomy. This is more for PMP, involvement of the pancreatic head and bladder trigone, and massive or diffuse involvement of the pleural space. Anything less than this, we can get a complete cytoreduction. But what do you do in ovarian cancer? When do you say what are your criteria for unresectability? We all agree that extensive small bowel involvement is one criteria. What about the others? Is there anything that you see on a CT and you call it unresectable straight away?
No, definitely not. It's very important to understand, unlike the colorectal cancer with peritoneal metastasis, gastric with peritoneal, or mesothelioma, ovarian cancer, no matter whatever be the metastasis in the abdomen, they're still stage 3C. So stage 3C, per definition, are with curative intent. No imaging today is perfect, no matter MRI or a CT or a FAPI-PET, which can outright say this patient is not resectable. No, there is always a chance that it could be cytoreducible. One absolute contraindication I would say would not be is diffuse involvement of entire small bowel serosa, not mesentery, because most of the time in ovary, mesentery on either side can be stripped and you can get away. But this bowel serosal involvement from duodenojejunal junction to ileal IC, where you don't get a adequate small bowel length and you end up with a short bowel syndrome. That is something in my center is the only criteria. Or extra abdominal intrathoracic not cytoreducible. The protocol we follow is if a patient has a pleural fluid, we always do a thoracoscopy before, even if patient goes to neoadjuvant, because there could be a high volume thoracic disease which might need cytoreduction when I go in during interval, or it could just be a cytology without any pleural disease. So I don't have to visit the thorax when I do a surgery or a diaphragm, transdiaphragmatic. It needn't have to be thoracoscopic. So these are the only two criteria which are absolutely no. Having said that, all the things which you enlisted, which is written here, would predict the duration of surgery and the surgical effort that has to be put in that patient, and number of visceral resection required where the morbidity starts slowly climbing 5%, 10%, 15, 20. So it's one of those conditions you will achieve CC0 at what cost, what duration, what patient performance status loss. So this is what I would evaluate before I take a call.
Okay.
I would make a comment about the function of the small bowel. If on your CT scan there are multiple sites or even one or two sites of partial bowel obstruction, in other words, the CT and the patient are telling you that this disease on the small bowel is invasive and it is interfering with function, then that patient, for me, has the number one criteria for the neoadjuvant chemotherapy and not moving ahead with a primary resection. I know that there's for the Memorial Sloan Kettering score, they want over 6. But I think that if you have this profound involvement, both functional and on CT of small bowel, those patients are categorically unresectable for a CC/0 or 1 cytoreduction. If you notice on this list by Memorial Sloan Kettering, numbers 3, numbers 4, number 5, all have to do with the appearance of the small bowel on CT.
Yeah.
So I think that the classification of the small bowel is crucial in making a judgment. You know what? In all of these cases, the peritoneectomies don't cost us much at all. They're very well tolerated. But when we know we're going to need to do multiple visceral resections, then we're going to get into problems. We'll get into complications and the like. So that focusing on the visceral component of the disease is I think extremely important. And by the way, sometimes gastric cancer patients do require a distal gastrectomy. That's not unheard of. And sometimes they do require total colectomy, and we'd like
Yeah.
to stay away from that.
Yeah. Yeah. Yes, Sartre.
Yep, we discuss the performance status of the patient and the extent of
Do we need to message?
carcinomatosis in terms of triaging the patients to neoadjuvant or upfront surgery. I think in gynecology, at least, we give a special consideration to the biology of the disease. It depends on how the disease is sensitive to medical treatment. And the surgical approach is varying concerning the different types of the ovarian cancer. For example, if this is a low-grade ovarian cancer, this cancer is almost don't have any sensitivity to platinum-based chemotherapy and has a moderate sensitivity to letrozole or anastrozole or new generation drugs like CDK4 inhibitors, which are, new generation anti-hormone drugs. And in those patients, of course, the surgery has a pivotal role because if you're able to achieve no complete, no gross resection status, you don't have any, too much medical treatment that could be important in terms of the survival of the patient. And of course, the massive splanchnic resections are okay for those patients. Either 2 bowel loops or maybe 3 bowel loops with stoma or maybe 2-stage surgery is also acceptable because the surgery is the only solution for those patients. The same is for mucinous ovarian cancer because it's proven that in mucinous ovarian cancer, if you open up the patient and if you don't achieve CC0 resection, your surgery then do not, improve the survival of those patients. But in high-grade ovarian cancer, especially in BRCA mutated and HRD patients, the approach is very different because for example, okay, I'm going to take out some bowel loops or spleen or whatever, do anastomosis, and if you get the complication, and if you deal with this patient for weeks trying to solve those complications, you postpone the chemo, and at the very end, you have much worse oncological results that you could get if you start with neoadjuvant. So this is why the biology of the disease is sensitive to medical treatment, I think plays pivotal role in terms of planning the surgical component of treatment of those patients for ovarian cancer.
Yeah.
I agree with Artemis. It's important for people to understand in ovarian cancer, we have a strong evidence. The last dose of neoadjuvant chemo to the first dose of adjuvant chemo with the surgery in between and the recovery phase of the patient. If it exceeds 40 days and or in the other way, within 3 weeks of the surgery, first adjuvant chemo is not delivered. For every month, it is delayed. we lose 3 months of overall survival. This is like proved. It's extremely important to be very sensitive. Whatever benefit we derive by achieving CC0, if we accumulate high morbidity and patient takes months together to recover, they already are starting to lose 9 months. And if you look back the Scorpio trial, and the recent all the trials published, the median time of failure in stage 3C today is 9 to 11 months, and median survival is between 14 to 45, and rarely it reaches 60 to 70. And you lose 9 months just by delay in delivering the adjuvant chemo on time because of your morbidity. We don't do a good justice to these patients. It's extremely important to understand this and go ahead. We already have a very high volume of evidence pertaining to this.
Yeah, so I think there are two important things. The first one is to get a complete cytoreduction, and the second one is to avoid complications. And one is sort of incomplete without the other. You do a very radical surgery, the patient develops a complication, all the benefit of surgery is sort of lost. And I would say, 3 weeks is a little hard when you are performing very extensive surgery. We could have about 6 weeks. For the less extensive procedures, I think 3 weeks is okay. But for the more extensive procedures, the cutoff could be 6 weeks. So in this patient, what does the panel think? She's 75. She has a lot of disease. No staging laparoscopy has been performed. The CA-125 is 1600. It's a high-grade serous ovarian cancer, BRCA wild type, HRP. What would you do? Her performance status, I've not seen the patient. She's being treated elsewhere, but I assume the performance status is 1 or 2, most likely to be 2.
Okay, so even though how much ever heroic surgeons we want to be, and we want to really do the primary cytoreduction, we need to keep various factors which all the panelists discussed. Able to achieve cytoreduction in first go, to end up with less morbidity, and to have less complications, send the patient back to the medical oncologist timely with a good performance status. Now, in this lady, we'll split and analyze one by one. Advanced stage 75, very high disease burden, and also some initial symptoms of bowel dysfunction. Performance status is not ACOG 0. Very unlikely this lady would be able to pull on without much morbidity if primary cytoreduction is done. So on case-to-case basis, this patient, I would refer to medical oncologist for neoadjuvant chemotherapy, keeping these things in mind.
I'd go a little farther. I'd be expelled from the MDT if I went ahead with a primary cyto on this patient.
Arthur,
Yeah,
will you be?
totally agree. Totally agree.
I totally agree. Especially, I'm sure you know the last trial recently reported on ASCO, that the Trust trial. It's the last and very new and very well-designed trial about the neoadjuvant versus upfront surgery in high-grade ovarian cancer. And this trial demonstrates almost the similar median overall survival in both groups. And so we know that in those patients, if we give the neoadjuvant, we do not really affect the oncological results of the treatment for high-grade ovarian. So why not, if we have a chance to have a better surgical outcome for those patients where, the surgery is just the aid to the basic treatment of those patients, which is the medical treatment, the platinum-based chemotherapy, at least in this group of patients. But according her molecular status, if she's BRCA negative and if she's HRD negative, I don't expect very much response to chemo. But nevertheless, the partial response is well expected here. So why
Okay.
not she have to
I would
get immune?
also like to add what Dr. Bistal. I entirely agree with what he told. For the benefit of participants, we are all aware of EORTC 55971 by Inash Vergot, then the Chorus trial, and then the recent Scorpio trial, which was performed, and now the Trust trial, which I was there when it was presented. All of them show, as long as you do the right surgery even after neoadjuvant chemo. I mean, don't de-escalate the surgery. Don't just think that you responded to chemo, everything looks rosy. You end up doing a THBSO, just simple omentectomy, some peritoneal biopsy. Don't do that. Do the right surgery for that patient even after chemo. Then the overall survival is going to be sort of same. But it's very important for us to know that Trust trial is the only trial which showed PFS benefit in favor of primary cytoreduction if you achieve CC0, if you achieve optimal cytoreduction. But it didn't show overall survival benefit as ultimate story. It's very important to interpret. That is the golden line. Able to achieve optimal cytoreduction in the first time and not to end up with mortality which would negate the benefit, and not to end up with more morbidity with delay adjuvant chemo still negate. So this is something is like holy grail. So how do you know this patient and no investigation is available? It's based on the institution, the expertise available. But Trust trial is the only one which showed PFS in favor of primary without benefit of OS. So we have all these 4 trials which showed same OS benefit, provided you do the right surgery after neoadjuvant chemo during interval cytoreduction. Don't de-escalate. That is where we lose the game.
Okay. So the next question is, to all of you, what is the role of bevacizumab? We are seeing it being used very frequently, especially when the performance status is not good. There's gross ascites, there's pleural effusion. And as such, there are 2 trials, both of which are negative for their primary endpoint when they evaluate the role of bevacizumab. So what are your thoughts on this? Does this patient need bevacizumab to start with or just the systemic chemo?
Okay, what I will do is it's very important to understand bevacizumab as a adjuvant, bevacizumab as a recurrent ovary, and a neoadjuvant. Here it's neoadjuvant. It's proved that if there is a recurrent ovary and if it is platinum resistant, bevacizumab has overall survival benefit. That is the only set of the patient where OS benefit, but it's not very high. It's just about 2 to 3 months. Second, we will come to adjuvant. If you have done a good surgery, you have achieved optimal cytoreduction, bevacizumab has no role in adjuvant. Only inadequate surgery, not able to achieve optimal cytoreduction, only then bevacizumab showed a marginal overall survival benefit. It's very sad that we have to fall back to bevacizumab with a bad skill to get a OS. It's like shame on us. Okay, now we will come to neoadjuvant bevacizumab. There are no randomized control trial which showed any form of benefit in a neoadjuvant chemo with bevacizumab, where you are going to do a curative interval cytoreduction. And the participant can read about GOG 0218 trial and then ICON 7. Having said this, only PFS benefit, no OS. Having said that, on a case-to-case basis, if you need a rapid symptom relief where there is no obstruction, like where Professor Sugar-Baker told, if there is an intestinal obstruction or even subacute, bevacizumab is contraindicated. In non-obstructed patient, but there is highly symptomatic, large amount of ascites, you want a rapid response. In those patients, bevacizumab may help, but you must be very, very careful that elderly patient like this patient, they're more prone for thrombocytopenia, bowel perforation, and delayed wound infection. So it may negate any benefit. So I'm not a great fan of using bevacizumab in this. Having said that, very selected group of patient may benefit bevacizumab, where we need to omit in the last chemo so you can still do the surgery within the window of 3 weeks.
Yeah, I completely agree with you. That would exactly be my strategy too. Artem, from the gynae oncology perspective.
Yep. There is, some hospitals use the bevacizumab in neoadjuvant setting, but in my department, we've abandoned it. We don't use it because I can tell you why. Because it is suppressing the angiogenesis, not only in the tumor, but everywhere. And we did the historical analysis of our data, and we find out that there was a double more rectovaginal fistula after colorectal resection in the group of patients who got this bevacizumab prior to the surgery. However, we keep this threshold. If you give the bevacizumab in neoadjuvant setting, you have to wait 6 weeks prior to surgery. So you can give it on your first and second cycle, and it's not recommended to give it on the third cycle of neoadjuvant. But we noticed that even if you give Bev on first on and the second cycle, there is still higher rate of fistula in patients who got the bowel anastomosis. This is why how we never give the bevacizumab in neoadjuvant setting. This is how we do to avoid the postoperative complication and to have a good timing of adjuvant chemo after the surgery, which is much more important than this suspicious oncological benefit of bevacizumab, as Professor Somashekar said.
Yeah.
Yeah.
We tend to create a stoma in most of the patients who've received neoadjuvant bevacizumab, especially if there's a rectal anastomosis. Because even if the anastomosis is very good, it looks, there's no reason to divert, but we often end up performing an ostomy just because bevacizumab has been given. So I don't like it either. And if the patient comes to me beforehand, I tell the medical oncologist, if you want to give it, please give it after the surgery. Please don't give it now. You can get a good response with your systemic chemotherapy. And if we don't get it, we'll see what to do. So, Dr. Sugarbaker, do you have any comments on bevacizumab and surgical morbidity, or it's
Our group would not use neoadjuvant Bev. They very often say, "Oh, we're going to save the Bev for later in the natural history of the disease." So upfront, bevacizumab would not be used, not especially in this patient who already has high blood pressure and she already has some thrombocytopenia. I think that it would, as you said, Aditi, it would make her subsequent surgery more dangerous.
Yeah. Yeah. Arthur, what is the practice in Brazil? Is it
Yes. I like also to avoid bevacizumab. Some patients are already receiving when I receive them. And when it happens, I like to wait at least 8 weeks until going to surgery. Sometimes we extend one cycle in order to doesn't wait a long time without any systemic treatment. But I don't like also every surgeon has some bad experience in surgery and bevacizumab. So
yeah,
I prefer to avoid also.
yeah. We are missing a poll. We would love to have a poll, but from next time onwards, we will put in the audience poll to see what is the experience of people who are present. So this patient, she went directly to the medical oncologist who started bevacizumab. The first cycle was split into 3 weekly doses, and then she was able to tolerate the 3 weekly cycles. The only adverse event she had was thrombocytopenia. And this was the interim analysis. The CA-125 came down to 38.9 from 1638. And the Kellim indicated that it is very chemosensitive disease. The score was 1.8. She had a complete relief of symptoms except for the mild weakness that was there for a few days after every cycle of chemotherapy. And then a FAPI PET scan was performed, which showed a reduction in the disease at all sites and complete resolution of the ascites. And I've not got the PET images, I'm just showing the CT images here. So this is the status after 3 cycles of neoadjuvant chemotherapy with bevacizumab.
Aditi,
Appears to be a
as we are looking at this, I also want to make a point. Traditionally, based on all the GOG trial and URTC, always 3 weekly paclicarbo and weekly dose dense pacli didn't have any difference in the outcome. But now we know that JGO, Japanese GOG 3016 trial, and the recent trial now has shown that in eligible patient who can tolerate with a good performance, weekly Pacli is actually now superior. So actually in my institution, we have been practicing this.
Okay.
And especially in elderly patient, it always makes sense to split the weekly Pacli. Weekly Pacli, in addition to being tumoricidal, also has an anti-angiogenic BEV-like mechanism because weekly Pacli also
Yeah.
is an anti-VEG. So
Yeah.
that's one of the thing people needs to explore in their MDT in such patients.
Yeah. I think this particular patient got it weekly for the first cycle because they thought she was unfit to get the full dose. So I think the CT looks much better now. And what are your comments on the
I would, I
CT?
would, yeah, I would take this as a excellent response. Like we, even though we say partial response stable, and so this is a good response. Now, CA-125 dropped from 163 to 38.9. Kelly index 1.8 actually suggests very high platinum sensitivity. I'm surprised this patient is not HRD mutated or BRCA mutated. I would expect such a fantastic response in such
Yeah.
patient. Symptomatically, patient improved, and I'm sure performance status, which might be ECOG 1, would have become 0.
Yeah.
And FAPI, even though not fully, completely reliable, but it itself shows metabolic and volumetric regression.
Yeah.
So what I would say, a patient who was borderline resectable or unresectable now probably is converted into a green zone of probably highly resectable.
Yeah. But I think all of you would still want to have a staging laparoscopy for this patient before committing to surgery. I think everybody agrees. Or would anybody like to directly proceed to CRS looking at the CT scan?
totally agree, but some services, some hospitals, it's possible to start the procedure of a cytoreductive surgery with a
Yeah.
laparoscopy. This
Yeah.
could be an ideal scenario.
Yeah.
Plan a complete cytoreduction, prepare for this, and start with staging laparoscopy, and then, if possible, go on and avoid a laparotomy.
Yeah. You save the patient one extra anesthesia. If the disease is
Yes.
resectable, you can go ahead with surgery in the same sitting.
And
I
it's not so much time added. It's
Yeah,
not so time consuming. It's
yeah,
fast to do it.
yeah.
Because
Uh,
it's important to understand radiological response automatically doesn't mean or equal to surgical resectability, especially small bowel disease and mesentery disease. So it's no harm in doing a single port laparoscopy before you just keep everything ready for a laparoscopy.
yeah. Dr. Sugarbaker, would you, you are one person who doesn't use a lot of staging laparoscopy. So what are your thoughts looking at the CT?
Yes, I think I would really like to be in on the staging laparoscopy on this patient to directly look at all of the abdominal pelvic regions. And we would perform numerous biopsies. And I like the idea of doing the laparoscopy and then the laparotomy, but but I would rather have all the information that I can gain from the laparoscopy, which includes histologic sampling. So we would use the staging laparoscopy as a separate procedure, a week before a planned or possible cytoreduction.
Okay.
Also, I would want to bring to this notice. Also, it is the individual practice of institution. Like in my institution, we have a neoadjuvant pipette trial going on. So it also is based on the institution what clinical trials you're doing. So like we would do a staging laparoscopy, and if we deem that this patient is even now not able to achieve optimal cytoreduction, we have a multi-institutional GCIG trial going on, a neoadjuvant PIPAC with concomitant IV chemo. So that's why we would definitely, then laparoscopy is the one. If I do a laparotomy, I lose that opportunity of a PIPAC. So that's why I would do that. And we already presented this in IGCS trial, which showed that the rapid Killam index drop and conversion cytoreduction at less morbidity is achieved with neoadjuvant PIPAC. But it's important to know it's not a high level evidence. No randomized control trial is there. It is still investigational. But if you are a part of that trial, laparoscopy makes very much sense to me.
Okay. Would anybody consider, let's assume you do the laparoscopy and the disease is completely resectable, but does anybody believe in giving all 6 cycles of neoadjuvant chemotherapy to such a patient or any patient? Or is your policy to operate as soon as the disease is resectable? Artem?
You know, amongst the ovarian cancer patients, there is a small but existing group of patients who've never been operated.
Mm-hmm.
Those are bad responders to chemo. Those are, bad frailty score, bad performance status patients. I don't know these patients, but there is a group, not that big, and so it's possible. I don't know what about this case, because the impression is that the disease is resectable, and of course we would perform a staging laparoscopy, assess the resectability of the case, assess how much shall we do to achieve complete gross resection, and if the extent of planned surgery is acceptable in this certain patient with her performance status and whatever, we would of course go on with side reduction.
Yeah, I think now most of us agree that surgery should be performed after 3 to 4 cycles if it's possible. There are few people who still like to give off all the neoadjuvant chemotherapy cycles. Some medical oncologists, they extrapolate it from breast cancer and the other solid tumors. But I think in ovarian cancer, the evidence favors performing surgery after 3 to 4 cycles. So we go in with the laparoscopy. If the disease is resectable, go ahead and resect it.
I also want
Yeah,
to point out, Aditi, we
yeah.
have two randomized controlled trials, that which showed if a disease has become resectable,
Mhm.
after 4 cycles of neoadjuvant chemo, delaying and adding extra chemo, each chemo added and surgery delayed would increase the resistance strain and overall survival starts coming down. It's very important to remember this in ovarian cancer. This is not like other diseases where you would give beyond maximum response and then operate. Already the evidence suggests that delaying surgery beyond fourth chemo is determinantal in a patient when it can be resected then.
Yeah. And also, if all your disease goes away, you'll not know what to resect. I have that concern also. If there's a very good response, unless you are doing a TPP or something like that, what do you resect? So,
Yeah. So
this patient,
just a
yeah,
comment,
yeah,
Aditi.
yeah.
We have to consider that a small proportion of patients that go to surgery after 3 or 4 cycles they are not able to return to chemo for the last 2 cycles or 3 cycles. This population is hard to predict if it was better to receive this whole treatment before surgery or not. We don't know if she's going to be status of have status to continue chemo. Probably this is that why some oncologists prefer to give all the treatment before the surgery.
So, in this regard, I have another concern. You know, when you do such a cytoreductive surgery, especially in ovarian cancer, then I always like to back it up with at least 2 more cycles of chemotherapy. Even if all 6 are given, there's no evidence that after all 6, should you give 2 or 3 more cycles. But I think they don't stratify it according to response. If the patient has a pathological complete response, maybe you can omit the additional 2 or 3 cycles. But if the patient has a lot of residual disease, you've done such an extensive surgery, there's a lot of residual disease, then that patient needs additional chemo. So that's also one argument that I always have with the medical oncologist and the patient, that even if you take all 6 now, after the surgery, you will have to take 2 more.
Me
I,
too. Me too.
yeah,
Totally agree.
yeah.
Yeah.
Artem, what do you think?
Yes, if we look at the evidence, there is strong evidence that CC0 resection is very important in terms of oncological outcomes. But there is no any evidence whether adding 4th or 5th cycle of chemotherapy is really, decrease the oncological outcomes. I don't know. It's questionable, but I agree with you. And if you feel that you cannot achieve CC0 resection with acceptable morbidity, why not? You can add 4th or 5th cycle of neoadjuvant. Why not?
Yeah, yeah,
Yeah, but I would like to add something what Aditi told. In all other solid tumors, say like in breast, we have what is called as RCB index, residual cancer burden.
yeah,
Even in testicular malignancy, germ cell, and then you give 1 or 2 cycle
yeah,
chemo if you are not able to achieve pathological
yeah,
CA. But
yeah.
in ovary, unfortunately, I
We have
agree with
no
you. You
right.
know, yeah, but there is one trial which actually looked at. One is I think +1 trial, and another was a Japanese trial, JGO 2019. Unfortunately, even if there is a significant viable tumor after 6 cycle of NACT, adding more chemo didn't show any benefit other than neuropathy and toxicity. But I agree with you. So we have not yet strategized adjuvant
Yeah,
based on the response if they have completed. So I would love to keep it 4, so you have 2. Then I don't have to fall
yeah,
into this
yeah,
PLO, PLOS trial and JCOG, and my medical onco would say, why I want to give more? 2
yeah,
still are
yeah.
there. I would say now we are left with 2, we'll complete them. So I'm happy.
Correct. Absolutely. Yeah. We have this chemotherapy response score that is, reported for all patients, but it has no clinical use. It's just okay, we know it, it's good prognosis, bad prognosis, but there are no clinical implications. So this patient was, again, she was being treated elsewhere. And a lot of centers in India are now starting PIPAC, and they are followers of Somashekar. So whenever they find that the disease is unresectable, the first thing they think of is PIPAC. So this patient had a PCI of 23, and we do not have the detailed PCI. We do not know why the disease was deemed unresectable, but they gave off 1 cycle of PIPAC with cisplatin and doxorubicin. And then the 4th cycle of neoadjuvant chemotherapy was given, and then a 2nd cycle of PIPAC was given, during which the laparoscopic PCI was 21. So this is when the patient came to us. So going back to the previous slide, after 3 cycles, your disease is unresectable. What would you do? Would you give more chemotherapy? Would you add bevacizumab, or would you add PIPAC? Or NIPEC? That's for Dr. Sugarbaker specifically.
Mhm. I'm waiting for the day when the ovarian cancer doctors are going to follow the lead of our gastric cancer doctors who are treating peritoneal metastases and begin to work with the NIPS concept. In other words, the neoadjuvant intraperitoneal is both systemic and intraperitoneal. So that happened a few places and then never finally materialized. But I think for me that's the future of neoadjuvant treatments for ovarian malignancy. Why should it work so incredibly well in gastric cancer and then not work well in this disease, which is much more sensitive to chemotherapy? The question about what to do at this point in time, our group would go ahead. We would not use PPAC. It's not available to us. We would go ahead with the additional 3, or usually the neoadjuvant is 4 cycles. We would go ahead with additional cycles of systemic chemotherapy.
Yeah. Artem?
Yeah, I agree with Professor Sugarbaker. We would go on with more cycles of chemotherapy here.
And you would still not consider adding bevacizumab. You don't like bevacizumab before surgery at all.
That's a matter of discussion. I wouldn't add it at the moment since we have more or less, a good response to chemo, but we would, assess the radiology after each cycle. And if we would feel that there is not enough a response from platinum and taxanes, maybe we would add the bevacizumab. So that, of course, this patient would not go to further surgery, maybe, or it's a matter of discussion. We discuss those patients after each cycles, depending on the response. But at this point, I would not add bevacizumab, still, believing that we could achieve more or less a resectable situation with platinum and taxanes only, because we don't have progression, we don't have stable disease, we have response. It's not enough, but nevertheless, the platinum and taxane works.
Yeah.
Why not? We can
Yeah.
go on.
I think so too. It's, the PCI is not too high. She has a good KELIM. The CA-125 is approaching the normal limit. There's a great chance that the disease could become resectable with systemic chemo alone. So this is when she came to us and her performance status was 1. She just had weakness and tiredness. Her appetite was good. She could do 30 minutes of brisk walking. Somebody had already introduced prehabilitation. She could climb 1 flight of stairs. All her blood workup was good. The albumin level was good. The CA-125 from 38 is now down to 16.5. And we performed MRI peritoneum, and the peritoneal cancer index is still high. It is 20. But I think if you look at the disease, a lot of it is calcified disease. These are the omental nodules. This is the disease in the pelvis, and there are these nodules all over, these calcified nodules on the bowel surface. There is a perisplenic deposit. It's not seen very clearly over here, but according to the radiologist, there is a lot of disease around the liver. There was some of these soft tissue nodules scattered in the abdomen. This is a nodule on the rectum, and there's this deposit about 3 centimeters in size in the pericecal region. So this was the detailed score given by my radiologist. The PCI is 20, and all regions have disease with calcification. Only two small bowel regions do not have disease. As such, it doesn't look unresectable. Um, what are your comments on this now?
Aditi, there is a discrepancy between the Kelly score and radiology images.
Yeah.
What I think that we discussed it on our project
Mm-hmm.
of reductive surgery, when you ask the responders to assess what we see in the abdominal cavity.
Yeah.
There is a suspicion that what the radiologists see and maybe what we see on staging laparoscopy, are we sure that those lesions contain active tumor cells?
Yeah. I think calcifications in this patient are an indication of response. And like I said, yeah,
Calcifications, scar tissue, whatever, because what we calculate, we spot abnormal tissue.
yeah.
We want to make sure that it's a active disease. Maybe in this situation, the FDG PET CT should more or less give more information, or maybe biopsy from suspicious disease, because I don't know, I'm not sure that all what you calculate is the active cancer.
So we will know after the surgery, but I personally think that MRI also picks up active
Yes.
disease because they use diffusion, they use
Correct.
post-contrast enhancement. In this particular patient, I totally agree with you. You know, a PCI of 20 for the disease as it appears seems to be too high. So maybe a lot of it could be burnt out disease. Uh, any other comments, Dr. Somashekar?
Nevertheless, doesn't matter. I'm not going to leave those dishes there. I'm going to resect it.
Yeah,
There
yeah.
will be very likely more than 53% of the time there is a trapped disease. But only thing is, like, where I might do a visceral resection to achieve, I may get away with a scissor dissection or something like that. At least if I avoided major bowel multiple resections, and I can still achieve, I'm done. And then what else is left behind? Without surgery, it's palliative to this patient totally.
So my
So
specific question to you is now she's had 2 rounds of PIPAC and the disease is resectable. Would you want to give a third one or would you take her to surgery directly? You know,
no, you told that the patient had a pipe pack, so that's very good. So do you have the
she
video
had
of
two
pipe pack?
PIPACs. Based on the MRI, I think I will be able to get a complete cytoreduction.
No
At this
problem. No, what
point,
I meant is, yeah,
hmm,
what I meant is in PIPAC, there is two types of evaluation which is done, which is not there in imaging. Number one, visual assessment of the saponification, then the response. Number two, minimum 4 to 5 biopsy in each PIPAC are done, and PRGS score is kept. So what our team told will give a very good idea: is it PRGS 1, 2, 3, or what is the response? Is it burnt out disease, or how much is viable? So that really would give a very good. Looking at Kelim and the way C105 is dropped, I would expect that there is a very good peritoneal regression. So that's one of the advantage that this patient had a PIPAC. I would love to see what is the biopsy and PRGS score in that.
so they have done the BiPAC, but they have not done the biopsies. So anyway,
That's
so
again the whole
Could
concept of PIPAC.
yeah.
Okay,
So
fine.
could I
yes,
ask
yes.
could I ask SP, what do you consider an adequate PIPAC treatment for an ovarian cancer patient?
Yeah.
1, 2,
So there
3, 6, 17? What is it that I'm being a little facetious here, but because sometimes it goes on and on and on. What would you if you were managing this patient and you were going to switch because the neoadjuvant chemotherapy didn't do what you wanted it to, what would you tell the patient would be the optimal PPAC number of cycles?
Yeah. Uh, mm, It's usually three. We actually published a paper on that in the Cancer Journal. The maximum response of the PIPAC comes after two PIPAC. So, but unfortunately, to know two PIPAC has responded, we need a third laparoscopy. So if we have gone in for third laparoscopy, then I always do a PIPAC. So this point actually is already done, that minimum two PIPAC and three laparoscopy is required to achieve, to know whether they have achieved the benefit. The macroscopic big disease would shrink by 50%, and then peritoneal regression score that has been given by the pathologist would be excellent. So this is what I would look at the patient, and I tell the patient it's going to be three PIPAC before I operate.
Arthur, are you performing PIPAC for ovarian cancer?
Yes.
No, we don't.
Okay, okay. So, based on this imaging, because she's 75, we had to discuss morbidity. We had to tell them what resection she required, and we do it for all the patients too. She requires, of course, a hysterectomy, bilateral salpingo-oophorectomy, the splenectomy, uh, a right hemicolectomy. Maybe we will be able to get away without a rectal resection, and I think the whole parietal peritoneum will need to be resected, and greater and lesser omentectomy, of course. So, do you think that for a 75-year-old who's had bevacizumab, who's had BiPAC, we do not have a geriatric department, and we do not use the frailty index, which I think is not such a good strategy, and we need to change it. But what do you think at this point? Is it worthwhile taking the risk of this surgery in this patient?
I would say that
Sorry, artist, go ahead.
okay. I would say that is reasonable. I think there's probability and this opportunity of receiving a complete cytoreductive surgery is the only radical and or also curative intent strategic step now. I think that is we tried all the treatments available. A kind of neoadjuvant intraperitoneal chemo would also help to improve the response, but the patient is sensitive and expected a really good response to platinum until now. So I would go on. Yes, I think that is feasible.
Okay.
Can I
Yes.
comment, Aditi? I think we need in this situation, in this patient, I think it's a perfect example. We need a trial in ovarian cancer like the Periscope trial in gastric.
Yeah.
I think most of us were shocked. I
Yeah.
mean, literally shocked when we saw the data from the Periscope trial. Yes, a few patients that had this, let's call it an extreme treatment, did it very well long term, but they had deaths, they had lots of complications. From an economic perspective, the prepaid healthcare groups in the United States, Kaiser, Humana, you can go on and on, they're not going to touch surgery for gastric cancer with peritoneal seeding.
Yeah.
I think we need that trial in this type of patient with ovarian malignancy to tell us that what we're doing with this radical surgery and with this extensive now HIPAC would be included in that, it is really the best direction in which to go, not just from a survival perspective, but from a total healthcare perspective.
Yeah.
Yeah.
I think that's a very, very good suggestion, because when we see what happened to this patient, we will realize how right you are about that. So, Arthur, do
I,
you? Yeah.
I think she did pretty well, tell you the truth.
Okay.
Compared
Yeah.
to what could happen, I think she really did okay.
Okay. So, All right. We counseled them about all kinds of possibilities. It was an educated family, and they had no financial constraints, of course, because they've had PIPAC also. So we would. I think we've had this discussion. Staging laparoscopy, if the disease is resectable, all of us agree that she should be offered surgery and not systemic treatment alone. So there are some scores for predicting morbidity, but what I find is all of them have some surgical intraoperative factors. And even if you use a nomogram or a score, at what point will you say the risk of morbidity is too high? So I guess the scores can help us counsel patients, but beyond that, uh, I, I mean, just because a score is high, would you still defer surgery in a patient that has resectable disease? I think it's a tough decision to not to tell this
The,
patient
the
that the
way
risk, yeah,
the way I would approach is I almost every month I have which would be there. You surgically would think that you can achieve, but I normally have a very frank discussion with the patients and family. Now, this patient, this is how I would put it. We will be able to achieve CC0 at a
yeah,
prolonged surgery, but likely Calvin Dindo grade 3 might touch as high as 30% to this patient. I would
yeah,
explain them they may have a much more prolonged stormy ICU stay than other people, and I
yeah,
would anticipate cardiopulmonary complications or chest infection. But I will put it this way, that all these morbidity are acceptable if there is an oncological benefit, that is a meaningful benefit after patient is optimized. And I have some patients and family who totally listening to this, knowing that if I achieve optimal cytoreduction, they have an overall survival benefit, but they just decline, knowing the
yeah,
quality of life issues,
yeah,
number of morbidities and this, and they just say, good, I'm fine, and at this age of 75, I would just want you to give chemo. And I say, beyond certain, we can't give IV chemo, because by then they would have accumulated neuropathy already, and
yeah,
single agent carboplatin other than the icon 07 trial has not shown benefit. So then I would just keep those patients. They say I would just need a palliative intraperitoneal pipac, and then at that moment, because we are not operated, a maintenance bev with or without PARP, surprisingly many patient and family accept this. They
yeah,
are not ready for reduced quality of life,
yeah,
30% morbidity, prolonged ICU stay with probable mortality crossing 2%. I really have one or two patients every month when I frankly explain, knowing very well they may achieve overall survival benefit. If I achieve CC0, they refuse. So it's a
yeah.
frank
Yeah.
discussion what patient and family is ready to take, and I would not discourage them. It's nothing right or wrong. I just leave to
Yeah,
them.
no, it is from our side. When the family refuses, the decision is very easy. But as a
Yeah.
surgeon, when the patient says, do what is right, when the ball is in your court, would you ever defer surgery? I think not.
Yeah,
Uh,
no,
yeah,
definitely. If they accept the morbidity, totally fine, yes. Because
yeah.
we know this patient will benefit if we achieve CC0.
Yeah. So I think I would also like to tell all those who are there that you need a really good team for this. Even if you're a great surgeon, if you don't have the intensive care backing, you don't have a good anesthesia team, you don't have good physicians, then it is very difficult to pull these patients out. And especially in India, you've got to be very wary of who's going to pay for the surgery, because if this patient develops complications, your cost could treble, they could be 5 times of what was estimated. Arthur, what about you?
Financial toxicity with Calvin Dindo toxicity.
Yeah, okay. Arthur, do you have any comments on the
Yes,
financial part?
because we have to know what's our goal to achieve resection or to get a good medical outcome. Because in this patient, the risk of postoperative grade 3 and more complication is higher than in population. So the risk is higher, and we're 100% sure that if we get the grade 3 or higher postoperative complication, this will really compromise our oncological outcome. It's true. So if I would speak with patient relatives and whoever, I would tell them this, and we would decide this, because there is a risk, and we have to understand, is this risk acceptable or non-acceptable?
Yeah.
I think in this case, the risk is on the border between acceptable and non-acceptable. It's a matter of discussion with patients, because in one hand, we want to get the best oncological results, but in other hand, we know that there is a very high risk of get the opposite of what we want to get here. The
Yeah.
risk is
Yeah. It's so in this patient, we started off with a laparoscopy. We confirmed resectability and we went ahead with cytoreductive surgery in the same sitting. She had a total parietal peritonectomy as anticipated, greater and lesser mentectomy, resection of the peritoneal ligaments and small diameter of the right diaphragm. She had a right hemicolectomy because of the infiltrative deposit on the cecum. But as I'll show you, the disease on the transverse and sigmoid mesocolon could be addressed with a mesocolic peritonectomy. And the only unexpected resection that we performed was a cholecystectomy, but I perform a cholecystectomy if there is extensive upper abdominal surgery, whether or not there is gross disease on the gallbladder. We performed an ileostomy also for this patient, and her PCI was 24. This is the distribution of the disease. So I would again like to ask the panel, would you perform HIPEC in this patient after this surgery? And would you would you perform an ileostomy? We oversaw all the anastomosis. The anastomosis was a side-to-side stapled anastomosis. A second layer of sutures was taken as is recommended for the rectal anastomosis. But we still performed a diversion because of the extensive mesocolic peritonectomies. So what are your comments?
I would like to add, like when we audited, because in our my team completed more than 3,000 CRS hypex. So it depends on the data and the patient. So this patient, even though is frail and elderly, albumin is quite good, responded well. We would rarely do any diverting stoma, even if it is rectum, up to resection. Usually rectosigmoid and right colon usually is the main burnt. We would not do that, and we audited, and out of 3,000 the leak rates even with HIPEC was 4.2%. So in my center we rarely seldom do any diverting stoma, because these patients are not irradiated unlike colorectal CA. So we would not do that. For right colon resection, never we would do that, because right colon is both the time there is a serosa and it's a very good anastomosis, unlike rectum. So we don't do that. But having said that, it's institutional policy, and the surgeon doing at that moment would take the right decision. It's there is no wrong or right, but in my center we don't do. Now, role of HIPEC, I would interpret this way: elderly patient who underwent such a major resection, what is the lactic acidosis, what is the blood gas analysis, what is the condition of the patient, does patient by then need a pressor to maintain their blood pressure at the end of it, would decide I would add HIPEC or not, because a good cytoreduction itself has given a good overall survival benefit, and I don't want to lose it by even adding 2% of extra morbidity and then be over ambitious. But in this patient, already patient has received 2 cycles of intraperitoneal, some form of chemo. If you study the evolution of ovarian cancer, Deborah Armstrong trial and also Maury Markman trial, it is proved as per all the GOG trial, some form of intraperitoneal therapy in advanced ovarian CA, in addition to systemic chemo and surgery, do benefit with overall survival. Now, what is that best form of intraperitoneal? Is it port-based normothermic chemo? early postoperative EPIC or normothermic intraperitoneal neoadjuvant chemo or HIPEC or PIPAC, nobody knows because each trial is different. OV HIPEC says it's a HIPEC, and then GOG trials show the best result ever is 4 cycle of intraperitoneal port-based chemo. But I would interpret this way: 2 cycles of intraperitoneal some form chemo has been received. Elderly patient already with like a borderline morbidity and advanced surgery. I would not do HIPEC in this patient.
Okay.
I would comment. I don't really understand the need for the ileostomy, Aditi. A right colon resection, and you did an diverting ileostomy above the right colon, the ileocolic anastomosis. Is that correct?
Yeah, it is also not my practice to perform an ileostomy, but this patient had transverse and descending and sigmoid mesocolic peritonectomy, and a lot of patches of the mesocolon were removed. So at one point, I was a little bit concerned, and which is why we performed the diversion. The second thing was it took a lot of time to get all the disease out than it usually takes because there were a lot of tiny nodules over the entire small bowel mesentery, and there was a lot of disease on the mesocolon. So it's not my practice to perform an ileostomy, especially with the second layer for a right colon anastomosis, but this case was an exception. And because of the duration of the surgery, she was not on vasopressors, and she was okay. There was no lactic acidosis, but just because of her age, and she already had intraperitoneal treatment, she already had bevacizumab. I thought a 90-minute HIPEC would be just pushing the limits too much, and we decided not to do the HIPEC for this patient.
Yeah. So I understand the ileostomy now better. It wasn't just to protect the ileocolic anastomosis,
Yeah,
which I'm sure you thought was totally adequate. It was to protect the bowel that had been traumatized and the
yeah,
traumatic sites repaired. But it was basically to prevent fistulas
yes,
more than anastomotic
yeah,
leakages.
yeah.
Okay. So second comment, I would definitely use HIPEC on this patient. I think that our benefit that we see in the Van Driel trial, which is real but minimal, is the tip of the iceberg. I really think that a good HIPEC on ovarian cancer patients can boost their survival much more than was seen in the Van Driel trial. Yes, that was a good place to start this moderate dose of cisplatin with thiosulfate rescue. I mean, the dose of cisplatin that she's getting with that thiosulfate rescue is really very difficult to know. I'd much rather see a reduced dose of cisplatin without the thiosulfate, and then other drugs, which at least one other drug, and we would use a doxorubicin intraperitoneally in addition to the 50 milligrams per meter squared of cisplatin. And then we have the tradition of using the systemic ifosfamide along with that. I think it's a really complete and very effective HIPEC for ovarian cancer. I'd love to see a randomized controlled trial of that regimen versus no treatment, because I think that it's a very good and a much more the rationale for this pharmacologic approach is much better. I appreciate SP's comment. Yes, we should have some regional intraperitoneal approach in these patients. At this point in time, the only thing that is reasonable for us is HIPEC, and I would use it unless there is some overwhelming reason why the HIPEC should be withheld. And I didn't see that in this patient, tell you the truth. low anastomosis, I began to get a little bit less enthusiastic because no, I would not do a diverting ostomy. A diverting ostomy in ovarian cancer surgery is really not accepted. It's just not something that we do. It's like the mesothelioma patients. Do they get a diverting ostomy? Well, no, they don't. We just don't do diverting ostomies in that situation. Colorectal, it's okay. It's something that's done all the time. But I can't remember the last time that we did a diverting ostomy after an ovarian cancer cytoreduction.
Okay. So,
I agree, but I respect your decision, DT.
mhm.
If you see the Van Drill's beginning, the first patients, they some point of the casuistic, they reached more than 80% of diversion. And I saw an interview with the scientist, the researcher, and the surgeon,
Yeah,
and he said that he was not able to have complications. I completely understand the point of view of the surgeon
yeah,
that in this case, a fistula of the right column probably would be lethal for her, and
Yeah.
all these months and all these strategies would gone. I congratulate you. It was a courage decision to go on, and you felt not appropriate to go on of HIPEC and also with the anastomosis. Congratulate you.
oh, thank you. Yeah. I think for us, it's also difficult to, there's still a lot of skepticism about HIPEC. And if the patient develops complication, it's the HIPEC that gets blamed. So
Oh, absolutely.
Oh,
that
That's
is,
yes.
so true. That's so true.
and
Everything that goes wrong, it's the high pec. Yes.
yeah.
Yeah.
So at the back of your mind, you are living in some kind of guilt. Also, I would say that the first thing okay, I did not do the high pick. It's Artem, I know you do not perform high pick. So do you have?
No, we don't use it still.
Hmm,
Because I'm gynecologist only, I don't, operate mesothelioma or
yeah.
gastric or colorectal. So in gynecology, it is under testing, and we're awaiting strong evidence to implement the method.
Okay. Okay. So we hope to change your opinion by continuing to work with you. All right. So
Definitely.
these are some of the intraoperative images, and you can see, this is the splenic flexure. There's an infiltrative nodule right here on the mesocolon, and this is all the disease on the distal transverse mesocolon. There are these tiny calcified nodules, and remove them. We performed a mesocolic peritoneectomy. Did not take pictures of the completed resection, but there were large segments of the mesocolon that were resected. So this is, would you call this disease? This is the disease on the small bowel. I think it is disease. There's no doubt about it. And the whole small bowel mesentery had these tiny nodules. So how would you address this? Would you go with the scissors? Would you leave it? Because, there are some superficial nodules right at the junction of the serosa and the mesentery. Or would you use electroevaporation? Uh,
I think
I might
scissors
just
and a
say,
lot of patience.
yeah,
yeah. I use the curved Mayo scissor. I would remove every last one of these little nodules. I would put them in a cup. Usually, the cup will become filled with these little nodules. We'll send that off to the pathologist. It's amazing. Sometimes 200 or 300 nodules like this, and they won't see any tumor at all.
yeah,
So I think that each you can't ask the pathologist to make a histologic diagnosis on every one of these nodules. So we just put them together, and he makes
Yeah.
a section out of the massive nodules, and it gives us a lot of information. It actually, you feel good when you present them with 500 nodules, and they're all negative.
Yeah. So I'll save the histopath report for later, but I think that as such, we would not call this unresectable and go ahead and chase each one of them. I use a ball tip at high voltage and burn them and remove some close to the serosa with the scissors. So we went and sort of spent a considerable amount of time cleaning the small bowel mesentery. This
The
was,
problem with the ball tip is you don't have a specimen.
yeah,
So,
but we did take representative
oh, I see. You did take some. Okay.
yes,
All
from
right.
4 quadrants, 9, 10, 11, 12.
Okay.
Yeah, normal and abnormal both. And then this is the region of the DJ flexure, and that's the inferior duodenal recess, and there's disease here. So this is what the rest of the mesentery looks like. And then this is the spleen. So would you preserve the spleen if this is what you saw? Does this spleen need to be resected? This is the first look.
I cannot see the splenic hilum.
Okay, so you want to see the splenic hilum? I'll show it to you. Anybody else who would commit to a splenectomy just by looking at this picture?
No. No.
No.
Okay. So this is what the hilum looks like. This is the splenic capsule. There are these nodules. This is the hilum. This is the inferior pole. Would you perform a splenectomy?
Yes, I would. Looks
Yeah.
like there's a lot of disease in the fissure there, the splenocolic ligament, and I would imagine the same process will be operating posteriorly also. So I
Yeah.
would remove the spleen, and then all of this fatty tissue and soft tissue that basically is kind of an extension of the greater omentum can be very nicely removed, and then just ever so carefully expose the tail of the pancreas in order to individually ligate splenic arteries and veins.
Yeah.
Not conglomerate ligation. Every last little, if you can get 5 or 6 vessels ligated and divided at the tip of the spleen, much better than like doing the entire splenic artery or the entire splenic vein. Go out as far as you can on the tail of the pancreas in order to take those vessels, in order to avoid any pancreatitis.
Okay. So this, that is what we did, and I do have a video, but I don't have the pictures. So these all these white spots, I call them disease. Even if you are able to free the ligament, even on the medial surface, there are a lot of nodules. So we performed a splenectomy for this patient, and this is all her intraoperative details. We ventilated her prophylactically. The surgery took 435 minutes, and we put in abdominal drains and chest tubes in these patients. We will retain the Rein's tube and Foley's after this surgery. And she had a stormy post-operative course. On post-operative day 2, she developed atrial fibrillation that kept recurring. She had hemorrhage, which was self-limiting on post-operative day 5, but we had to transfuse 3 more units of PAD cells. And we just performed a plain CT. We avoid giving contrast in these patients unless there is a specific indication. So the CT showed postoperative collections and one hemorrhagic collection in the pelvis, for which we decided just to observe.
Did this patient develop pleural effusion? In some of the images, the basal cut shows significant
Yeah,
pleural effusion.
that was just the routine post-operative effusion. It resolved. We did not have to perform any aspiration for it. So, any comments on this post-operative CT? I'll just play it once again.
You know, I would these post-operative CTs. Maybe I shouldn't admit this, but we almost always, on a major cyto like this, whether the patient was doing well or not doing well, we would get a CT somewhere between
Yeah.
5 and 7 days post-operatively. And a lot of times we found things that we had not expected, and we could move ahead with some sort of intervention. So I don't feel, what should we say? I don't feel embarrassed by having to perform a post-operative CT on these patients who've had major cytos. I think that it's kind of part of their post-operative course.
Okay. Yeah.
Could I just make a comment on
Yeah.
removing portions of the capsule of the spleen in order to preserve the spleen? I did that on a couple of patients. I can't tell you exactly how many. And then I had 2 delayed ruptures of the spleen. Both patients almost died. Neither one died, but they were discharged from the hospital and had a delayed rupture of the spleen, had to come back by helicopter on emergency basis. It was one of those huge kerfuffles that you really don't like to be associated with. But as a result of my experience with partial removal of the splenic capsule, I have abandoned and a lot of it is because these patients now are all on post-operative anticoagulation. I think that's one of the issues. But I don't recommend, from my experience, resections of the capsule of the spleen in order to remove nodules. And I'll just tell you about those 2 delayed ruptures, which were very traumatic for the hospital staff and for the patient and their family. If you can imagine, just beginning to get on an airplane at National Airport and then collapsing and needing to be taken by helicopter back to the hospital center. I mean, it almost makes the newspaper. You know, it's not something you want to have to deal with.
Yeah. So, a lot of times splenectomy is iatrogenic. So
Yes.
I think we can at least avoid that. There's a lot of disease. It's the costal angle is narrow. You are dissecting in the deep, and so at least that could be avoided. So this patient,
And it doesn't seem to cost you anything. If people
yeah,
have looked at splenectomy, no splenectomy, it doesn't cost you anything in terms of your post-operative care or the patient's life subsequently.
yeah,
Actually, in my institution, a advanced peritoneal PSM case always has a post-splenectomy vaccination done well before they come. Most of them are elderly; they are prone for either way pneumococcal. So that's one of the pre-op preparation, like in prehab we have, because we know either the vaccine has to be given 2 to 3 weeks before or at least a month later. So I don't want to miss that window. We always vaccinate them.
yeah. So this we tend to give them if we are sure, like in this case, it is preoperatively. If we are not sure, then within the first 7 days of surgery. That is our policy. So this patient was discharged from the ICU on postoperative day 10. On day 12, she had septic shock with respiratory distress and hemodynamic instability. The blood and urine cultures were negative. The drain fluid grew Klebsiella pneumonia and methicillin-resistant Staph aureus. So we escalated the antibiotics to carbapenems, glycopeptide, and the intensivist got a beta-D-glucan done, so we gave her an endalofungin also. We did not have to intubate her with non-invasive ventilation. She could be managed. We changed the lines. She was discharged from the ICU again on postoperative day 15. She stayed in the hospital for for a total of 28 days and in the ICU for a total of 13 days. And this is the histopathology report.
Could
So,
I comment, Aditi, on the MRSA?
yes,
We have had MRSA epidemics at the hospital center. I think that the MRSA is an intraoperative contamination.
okay,
It's a ubiquitous organism, very difficult to eradicate from the people who are performing the surgery, the surgeon, the assistant, the nurses, whatever. And a lot of vigilance in trying to keep down the incidence of MRSA infection in your operating room personnel, I think is worthwhile. Our hospital would have surges of MRSA infection, and then it would go down and up and down. And it's a bad organism. People don't die from it, but
yeah,
it does cause a lot of problems post-op.
yeah. I also think sometimes, the ICU is the issue because if there are a lot of patients with medical illnesses, then in
Yes.
that kind of an ICU, our patients tend to get more resistant organisms growing wherever they are growing. Whereas if it's a surgical ICU where the other patients just come in and go, then we do not have so many resistant bugs. They are
Yeah.
not so difficult to treat.
That is why
So,
one of the thing in my institution, we try keep not keeping the patient in medical ICU. Limit as much as possible the ICU stay and sort of take down to step down high dependency, which is
yeah,
purely surgical patients and not this toxic medical patients who are on prolonged ventilation and stay there not in days but in months, and they
yeah,
accumulate all sort of bugs and which they give it to our patients.
yeah,
I totally agree with that. Those having our acute surgical patients right next door to a patient that's been in the intensive care unit for a month
yeah.
is just unnecessarily dangerous.
Yeah. So this was the histopathology report. She had a chemotherapy response score of 2. This was measured in the greater omentum, and all regions showed residual disease except the left subphrenic peritoneum. The splenic capsule was positive, uterus, ovaries, right colon, ileum, appendix. The GB serosor did not show disease, and the regional nodes were negative. So, any comments on this, Artem?
No, no comment.
Okay. We would expect, in view of the high chemosensitivity, that a lot of this would be burnt out disease, but somehow everything doesn't correlate. The low CA-125 level, the MRI, and then this histopathology report. There is a lot of residual disease. So,
Yeah, I would say this, Aditi. After seeing that pathology report, I would feel I would feel very good about having used HIPEC.
okay, yeah, I agree
So
with you. But uh, for me, it was too much.
yeah,
She got out for 2.5 months. We are not able to put her on chemotherapy. Even now, it's sort of we are going to start with low weekly doses of systemic chemotherapy. I was glad I did not do the HIPEC, to be very honest. Exactly the opposite of
Yeah,
uh,
but
you know.
we can't demonstrate that the HIPEC really leads to a higher incidence of grade 3 or 4 complications. I mean, the HIPEC seems to be extremely safe. Now, when we
Yeah.
were using the 5 days of EPIC5FU, we did see some additional problems, and I think we understand those better now. We had more pancreatitis, and that was the major problem with the long-term intraperitoneal 5-fluorouracil. But I actually think that 90 minutes, of course, I'm using the open HIPEC, and we're washing the surfaces continuously during the HIPEC. Those surfaces are so brilliantly clean by the time that 90 minutes is over, that I think we have less post-operative bleeds and we have less infection. And I can't demonstrate that because I don't have enough cases. But I don't feel that the HIPEC interferes with the post-operative recovery at all. Not at all. And in some respects, I like it. And I have to say, the anesthesiologists love it because the patient that's cold and maybe somewhat hemodynamically unstable, during that 90 minutes of warming, they come out with a normal temperature. There's absolutely no bleeding. The irrigation fluid that comes out is totally clean. So I'm a great advocate of the open HIPEC in this particular situation.
Okay. Somashekar, are you going to change your stance, or are you also going
No,
to?
see, I would just look at how the patient, because we clearly have a well-defined parameter between us and anesthetist. I would not decline HIPEC just because it's major surgery or multivisceral. I would purely go by what is the time it took, and how much is the patient, what is he doing at that moment, the
Yeah.
lactic fluid and then the vitals and pressors required or not. So I agree. Then I would not shy, because I would tell the patient I took so much of effort to reach there. So let me add that last, already the morbidity has come from the cytoretic surgery. Water is going to come in the
Absolutely, yeah.
patient. In this patient only because multiple pipects were given. I am just not sure, but I agree. I would
Yeah.
not shy. If I can add HIPEC, I would definitely love to do that all the time.
I would be concerned about the 2 extra hours of operative time. So that was also a concern. Anyway, next time, there's always a next time to be more aggressive. And so now we could, there's one question in the chat that I'd like to put to all of you. It's from Dr. Guillermo Flores Ayala from Mexico. And it's a comment that these nodules could be addressed using an organ beam also. And we did this consensus on cytoreductive surgery. Artem was part of it. Dr. Sugarbaker also voted. And the panel said that no organ beam, no QSA, and no plasma jet. They said only 50% said that it could be used. So, what are your comments on using these devices to remove these tiny nodules?
Yeah, see, like I use all of them. So I have a plasma jet. I always have argon, but it's very important to understand cold scissor resection of a disease is the best control
Yeah,
of that disease. Like
yeah,
there's no compromise on that. Like
yeah,
wherever you can do cold scissor resection is superior. Suppose you are in such vital areas near neurovascular bundle, major vessels, or if you think that you may end up with opening up the bowel, so you need to sew it 2 times, or you may end up with visceral resection. Then, if you can't use a cold knife scissor, remember argon plasma is not to burn, it is a hemostatic.
yeah,
It's very, very important. It is a surface laser not a resective laser like a CO2
Yes,
laser. It is
yes,
when you do a mesenteric stripping or you've done a Gleason capsulectomy and you have a oozing, and that is where argon. That's where I use argon plasma.
yeah,
So the plasma jet I use when there are extensive adhesions, and if I start doing a scissor mobilization or a diathermy, I may end up with multiple small serosal injuries which I need to sew second layer Lambert before I do HIPEC. Then I use plasma jet. So we should not get confused. Argon plasma is not for ablation, and
agree with you.
plasma jet is not for resection. Next to cold knife scissor, very high electrodesiccation of ballpoint
Yeah,
cautery is closest, but not superior to cold knife scissor.
that is that is very right. I completely agree with you. Anybody else who would recommend these devices to remove these nodules, because they are not going to destroy the tumor. They are sort of ineffective. I've tried to do it with CUSA, I've tried to do it with Tasmajet, but it doesn't work even on these tiny nodules. It has to be a scissors, or it has to be high voltage electrocautery to burn the nodules.
I just have to say hello to Memo. Hello, Memo. Always good to hear
Yeah,
from you.
yeah. Okay, so now we've reached the end of the discussion, and adjuvant chemotherapy has been delayed. So what are your comments on the case overall? We will be completing the chemotherapy and putting her on some kind of maintenance, perhaps PARP inhibitor, because now PARP inhibitors are recommended even for BRCA negative disease. You can give PARP inhibitors to everybody. So given her history, I think PARP inhibitors would be better than bevacizumab in this particular patient.
Yeah, what I would also do is a lot of viable disease. I would repeat a HRD plus test on this. Because a small volume of disease HRD on a pre-op which was
Yeah,
normal, and I don't know BRCA done was on germline or somatic.
yeah,
Aditi?
it was both. It was both.
Somatic.
Started
Okay.
with
So
yeah,
yeah, what I would do is I
started
would
with
repeat a
somatic.
HRD plus, because sometime you may have enough good tissue, and then you may be lucky. If HRD is mutated, then I'll put on rucaparib. If BRCA, which is negative now, I can't put olaparib. But I would go by the PRIMA randomized control trial and put the patient on niraparib.
Yeah,
Because the current evidence of PARP inhibitor when HRD is not present, positive, and BRCA is not mutated, wild type is PRIMA trial, and I would put on niraparib. Even though the benefit is in the tune of 18, less than 20%, it's fine, because
yeah,
already patient has delayed the chemo, and bevacizumab definitely I don't think patient is going to tolerate now after the surgery just coming out of it. And bevacizumab, I'm not convinced if you're done CC0 will benefit, and it's going to be 1.5 year. So I would put the patient on niraparib and follow the patient.
yeah. Autumn?
Yes, I agree. I agree.
Okay.
Maybe niraparib could be an option here. If not possible, maybe olaparib, even she's HRD negative, could be an option because this drug demonstrates some modest benefit in those patients. But
Yeah.
niraparib should be optimal for this patient if available, of course.
We will now have a biosimilar in India. It's going to come in the market very soon, or it's already in the market.
In India, we have all the three PARP inhibitors. So,
Yeah.
Believe me, in Armenia, we use Indian biosimilars also.
Yeah.
absolutely.
Okay.
I had to.
I think we've reached the end of this discussion, and we would like to have your comments one by one. Overall, what was done, was it reasonable in retrospect with these complications? Would you have opted for no surgery? And what kind of survival do you expect for this patient?
Aditi, the summary of this from my side before my esteemed panel would say, Number one, age in itself is not a criteria to deny a curative treatment. Very important to understand. Go by multifactorial. Don't just go by age. Remember, we'll all reach at that age, and I would not my surgeon to deny me a surgery just because of my age when I can be a candidate. Second, careful selection and good imaging and use of judicious laparoscopy and good rehab to the patient and multidisciplinary approach, opening a channel of good discussion with patient and the patient family, to accept extra morbidity in order to achieve a good CC0 resection, which in itself is the only chance for this patient, is actually a message. We should not shy away. You get tough cases, you get morbidity. You don't have to worry about it. You want a palliative resection versus a reasonable chance of coming out of it. So these are 5 take-home message from my side.
Okay, thank you.
My
Artem?
side,
Okay, yes,
all
Artem.
I think that all the technical and theoretical points were discussed very well of the panel. And I would like to congratulate the PSOGI for the initiative and also Aditi for the case and the courage to bring your work, and to congratulate all my colleagues and the members and delegates in the webinar.
Thank you, Artem.
Aditi, first of all, congratulations with successful surgery. As a surgeon, I would congratulate you with this brave case. And that's, of course, it was very controversial case, and the time will show what's going on with the patient. She is under high risk of developing relapse very soon, but maybe she would, survive. Whatever, it was very interesting. Why I love this webinar, because you put not very academic, but very special and controversial cases from real life. It matters, and thank you very much for this.
Thank you. Thank you, Artem. Dr. Sugarbaker.
Yeah, Aditi, again, I always have to start off by thanking you for preparing the case. It's not easy to do it. It was beautifully presented, and its clarity made the possibility of our discussion possible. So many thanks for doing this. This is number 47. And it shows that SOGI is really devoted to best possible patient care that is possible. I think that this patient did have a class 4 complication. It's kind of the least severe class 4 complication, which is a return to the SICU. So I don't feel so bad about that. 28-day hospitalization. Oh my gosh, I can't tell you how many people had a 28-day hospitalization under my care. So I don't worry about that. I think she had, despite starting at a very bad point, starting at advanced disease and aged and infirm, I think that her course was totally and completely acceptable, and that she has been given the best oncologic result that is possible. I would say that a number of the GYN oncology people here would probably put this lady into follow-up. They'd establish a follow-up plan of CA-125 and CT scans. And since her subsequent treatments are quite delayed, I wouldn't doubt that she would go into follow-up, and then she'd only be treated if indeed she shows evidence of progressive disease. Because I think her treatments were very adequate and optimal. It's been a great pleasure to be a part of this case presentation. Thank you very much.
Okay, thank you, Dr. Sugarbaker. And we have a very special guest, Dr. Guillermo, who has been a very active contributor to the sessions when they were on Twitter. So we would like to have a few words from you before we close.
Yeah, I'm making my rounds at my center, but obviously, magnific case. This is what happens in real life. The patient comes to us looking for help, and still, for the world of carcinomatosis in ovarian cancer, surgical resection, complete surgical resection, is still the best rate. So, thanks so much for having me, and it's a great pleasure to see you all. Have a great um, end of the year and the best for January.
Okay, all right.
Also, I would like to add, now that you have a good tissue in this patient, I would do a alpha folate drug test testing, because we have ADA antibody drug conjugates, miroxatumab available, which would add extra 9 months of overall survival. And it's available in India now, this test, and we know 93% of them are positive, and they will benefit with the ADA, which is available, antibody drug conjugate.
Yeah.
And SB, can I ask you, would you start that without evidence of disease?
No,
Or would you
only
want
when they recur. Only when they recur.
so this in other words, you would put this patient into follow-up, and if indeed she recurs, then you would treat her with this new agent. Is that correct?
Yes.
Yeah, that's what I'm quite sure that that's what we would do here. But I'd be interested in what other people would say. I don't want to prolong your seminar here, Aditi, but I would be interested. Should this patient be treated now, or should she be allowed to recover and enjoy her life, and then maybe she's cured? I don't know. It's 50-50 perhaps. So should be adjuvant treatment now, or should it be delayed until we can demonstrate progressive disease? Artem, what would
I would put
you?
in this patient is niraparib. All I would put at this moment in this patient is a tablet PARP inhibitor.
I see. Okay.
Maintenance near upper event. If she recurs, why not get the biopsy, check the folate receptors, and mavitruximab should be an option. And this is a new drug, and initially there was a big everybody was very happy with this, but of course the effect is not very strong.
Yeah.
Nevertheless, currently this is the only option for platinum-resistant ovarian cancer on the market.
So as the treating surgeon, my concern is whether we've done too much, because if she did not have the surgery and she was, remember, her ileostomy is still not reversed. So she's still living with an ileostomy. And like Dr. Sugarbaker said, there should be a trial that compares surgery versus no surgery in this patient. So if you don't do any surgery, just put this patient on a PARP inhibitor, she could still live for 1.5 years. And with this kind of surgery, complications, early relapse, we don't know if the recurrence will be amenable to treatment or not. So I would really like to see if this patient, with so much of a delay at this age, derives benefit from surgery. I would want to see in future more robust evidence that tells me that what was done was right for this patient.
Yeah, I have to, if I could just follow up on that, Aditi.
Yeah.
As the systemic treatments in this disease become more and more effective,
Yeah.
we as surgeons giving our regional treatments, we must understand that as these systemic treatments become more effective, our regional treatments become less important. And as in the Periscope trial, they may disappear. So I think that we always have to be aware of what's happening with the management of systemic disease.
Yeah. Completely agree.
I totally agree with you, Paul, but I would, change a bit that it's not disappearing, but it is changing.
Yeah.
It is
Yeah.
changing. The surgery is changing. It's an evolution, because if we forget about our enthusiasm, if we forget about our efforts and years we spent on developing of this type of surgery, if we go away and try to look at the surgery as not the surgeon, you get that the surgery is the barbaric procedure.
Yeah.
And of
Okay.
course, if you change the place with your patient, if anybody comes to you and asks, would you like to get, to undergo this big surgery, or would you like to get some pill and to get treated? Of course,
Yeah.
personally, we should be very happy to get the pill and to get treated. The humankind is moving toward this. The same happened to infection, because pre-antibiotic era in the medicine was totally based on surgery.
Yeah.
Once we learn to treat the bacteria, everything's changed. I think the same will gonna happen with the cancer in the future, but currently the role of surgery is pivotal.
Okay.
I agree with you, Artem. I nowadays, because of the PSM program we run, like we do about 280 CRS HIPEC here in my center. Of late, patients and family are opting for better quality of life than a major surgery. You
Yeah.
will be astonished. I have one or two eligible patients who are eligible for CRS, HIPEC, and curative, who are well informed. And when I explain them everything, even in a successful surgery, come out without mortality, the time taken for recovery, morbidity. Surprisingly, many people opt for quality over quantity, and then they just say, "Yes, good, you explained. I know I am eligible. You would like to do surgery, and I would have overall survival." Knowing everything, I opt for better quality of life, complete the systemic chemo, do palliative pipacks, and just keep me on medications. I don't want a surgery. I'm surprising. The perspective of mankind on very major surgery with benefit is actually changing, and we have to honor that.
Yes, yes, the patients are changing. They are much more demanding than they've been 10 or 15 years ago, and the complications are hardly accepted today. If you compare it to the patients 10 or 15 years ago, they came to you and they say to do whatever you can, but now the situation is changing, and people expect quality of life first, almost everybody. This is why we were moving towards this. And I think our specialty is not disappearing, but evolving
Yeah.
towards the less traumatization, towards, achieving the good quality of life, which is priority today. It's priority.
Okay. So I think we will end on this note, and it's been a great discussion. It's we covered everything there was, and thank you all. Thank you for your time and for all your expert comments. Thank you.
Thank you. Bye bye.
Okay.
Thank you, and good night.
Thank you.
Thank
Oh,
you.
thank you so
Bye.
much. Thank you, Aditi.
Bye.
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 Bye bye.
Bye.